we've been in our markets for 80, 90, in some cases 100 years. We're there to stay, and we want the community to view us as part of the community. And it's important for us to be viewed that way.
Welcome to the Healthcare Grind, formerly the Healthcare Hustle. We do what entrepreneurs often do and pivoted our podcast name in the first couple episodes because we realized someone else has that name, even though we did quite a bit of research. Oops. Regardless, this is still the podcast where we cut through the noise in the healthcare industry to bring you the latest trends, innovations, and insider insights. I'm Jess Harthcock, and I'm joined by my co-host, Lon Heck, as we embark on a journey to connect early-stage healthcare companies, payer executives, and investors with the knowledge and perspectives that matter most. Get ready to grind in the fast-paced realm of healthcare innovation. And for more advanced content, go to healthcaregrind.com.
Good morning, everyone. This is Lon Hecht from the Healthcare Hustle. It's great to have you on the show this morning. I'm joined by my wonderful co-host, Jessica Harthcock. Say good morning, Jess.
Good morning. How is everybody?
Since they're probably not going to respond back, we're going to take it as they are doing incredibly well today. We are joined by an amazing guest this morning, Mike Rapach. Mike is the president and CEO of, and I want to make sure I say this right, CareFirst Community Health Plan of Maryland. I always tend to think of CareFirst as the big blue that's down in the Maryland, DC, and Virginia area. But we have a fantastic guest this morning. We've had the opportunity to get to know Mike over the last year. And Mike, do you just want to say good morning to the listeners?
Yeah. Good morning, everyone. Thanks for joining us.
Great. Well, thank you so much for joining us. And it's going to be a great episode today. We're going to talk about a few things. We're going to start off, kind of give everybody an orientation to the different types of health plans that are out there, just so you can get a really basic understanding. And then Mike is going to actually take us through a profit and loss, which I know doesn't sound that exciting, but he's going to take us through a P&L statement so that he can help us understand who are the major players and what's really important to them as they're making decisions. Once again, Mike, this podcast is really designed for early stage founders, for investors and health plan execs. Even though you may say to yourself, health plan execs should know this, most people tend to think about things in their own silo. So you're probably going to be expanding things out, the information and knowledge for a lot of different folks. So why don't we get things started off? And Mike, do you mind giving us a little background on the different types of health plans that are out there, just to ground our audience?
Absolutely. So when we talk about health plans, we'll be talking about the United States, as it's kind of its own weird model, as opposed to what the rest of the world does in terms of much more government-driven healthcare models. So we look at the US, we have healthcare really either driven by your employer or by the government. On the employer side, you have basic risk plans that are usually for small companies and that are handling a very small pool of employees kind of predictably, and they pay a flat rate per month to an insurance company, and then the insurance company handles the risk of the claims. If there's good claims, then the insurance company makes money. If there's a lot of excess claims, the insurance company doesn't. On the other side of that is something called Administrative Services Only, or ASO, and it's a self-funded approach where the insurance company simply acts as an administrator and passes the claims cost on to the employer to pay directly. On the individual side, you end up with three types of things. Medicare, which is focused on insurance for individuals who are over 65 or have a disability. Medicaid, which is focused on insurance for those who are usually under the poverty line or very low income. And then the Affordable Care Act, or the individual marketplace market, which covers insurance for individuals who don't have employer-based coverage, but would like to get health insurance through other mechanisms.
That's really helpful. Could you just take it a step further? I hear people talk about fully insured and self-insured all the time. Can you help folks understand, fully insured equals this and self-insured is ASO? Can you kind of take it a little further with some of the acronyms that people are going to hear on a day-to-day basis?
Sure. It's health insurance. So we have 1,000 acronyms. We love them all. So when you look at...
Well, I don't know about that, but we use them all.
We love most of them.
Absolutely. So we look at Administrative Services Only, ASO. That would be a self-funded plan. It's usually large employers, and they're focused on basically taking the risk onto themselves. They'll use things such as stop-loss insurance to mitigate the really high-cost claims, such as a transplant or a rather complex accident. They'll use reinsurance mechanisms as well to push some of the cost onto another insurer who's willing to take that on for a premium. All of that really becomes the employer is buying access to a network of providers that the insurance company provides. Once they have access to that network, then their employees can leverage it. The insurance company takes the claim, processes it, manages the roles, does a little bit of care management, which is basically trying to make sure that the provider is doing the best clinical solution for the right cost, and then passes on those claims and that cost back to the employer group. So about, anywhere from 250 and up employees, a lot of companies will take this approach because it's a good way to manage their cost and manage the risk. On the fully insured side, so these are also referred to as at-risk customers, you have companies that are smaller or feel that they're risk full. They have a lot of young employees, and so there's a lot less risk for them to take on. And they'll get a flat insurance rate annually from an insurance company. Now, the insurance company then is taking on all of that risk. So if there's a big transplant claim or something else that causes a very high cost medical need, the insurance company has to have reserves. They have to have a financial position that will protect them from basically paying out more in claims than they would get in revenue. So that's really the two sides of the employed picture. And it's pretty consistent across the country, across all the national players, the Blues, United, Humana, and now that they're getting out of the commercial side, you should say, Cigna, Aetna, all pretty much work in that same way.
Got it. Makes a lot of sense. So thank you for that. Now, if we could go backwards, because I'm sure the audience would love to learn more about you. Can you give us maybe a minute overview on yourself? I mean, I've had the pleasure of knowing you for probably the last year, getting to enjoy a few bourbons with you along the way. But I'd love for them to get to know you a little bit as well.
Absolutely. So I have been in healthcare and health insurance for over 20 years. Prior to that, I was in banking. And there's a lot of people who make the transition back and forth between banking and health insurance, as there's a lot of similarities in how the businesses work, the dealing with the regulators, kind of the whole nature of things. I've been with CareFirst about 3 years, managing their Medicaid and Medicare businesses within Maryland and the District of Columbia. Prior to that, I was with Centene, managing their Medicare and Marketplace, the Affordable Care Act businesses in Pennsylvania. And then before that was with Highmark, doing a lot of national efforts on helping them with outsourcing, with United Healthcare, with Coventry Healthcare, really working in technology, implementations, all of the business lines, kind of everything from the commercial side through the government programs, through workers' compensation, through pretty much everything you can do in the health insurance business.
Awesome. Well, I don't think we could have a better guest to talk about all the different types of business than Mike. So really appreciate that.
One thing I also wanted, Mike, I'd love for you to touch on. You're also a professor, aren't you?
I
think that shows when you talk.
A professor of what?
You love to teach.
So I am currently teaching at the University of Pittsburgh's Katz Business School. I am an adjunct professor there teaching business strategy. So every Monday night, I get to sit with a group of 40 students who would rather be somewhere else on a Monday night and work them through business strategy concepts and help them understand how to think more strategically for their future. It's a capstone course, so they absolutely have to take it. And every year I ask, okay, why are you here? Guaranteed, one student always says, because I have to take this class.
Of course.
Perfect answer.
Of course.
Awesome.
You do let them go early when the Steelers are on Monday Night Football, right?
Oh, absolutely. Absolutely.
Okay. Just want to make sure. I grew up, I went to Westchester University, a state school outside of Philadelphia, and the Phillies were in the World Series. And, you really judged a professor on whether they were letting you home for that game or you were not letting them home for that game. So I'm glad to hear you're on the right side of that.
Mike's on the top end. That's good.
Absolutely.
Exactly. So Mike, and maybe it's the professor in you, but Mike had the suggestion for us to share a P&L and maybe walk through it, because originally when we spoke with him, we said there are just so many different folks to know in a health plan, and understanding all the roles, it's critically important, especially, if you're planning to sell into the health plan. So Mike suggested that we pull up a P&L, kind of run through, and he can work off of that and give us an idea of who are the different roles or what are the different roles and what are the important things for each of those roles. So Jess, do you mind sharing that for us?
Mm-hmm.
All right. Mike, we're going to turn it over to you and let you take it away.
Excellent. So want to orient everyone to this to start off with. This is a basic income statement that any kind of health insurance company would have. The top line, of course, revenues. And revenues are either premiums paid by companies that are providing insurance, their fees for some of the administrative services pieces we talked about earlier, or their premiums received from a government entity, either the state or the federal government, for the Medicaid, Medicare, or ACA businesses. You'd also have in this revenues, depending on the nature of the company, fees for dental insurance, fees for vision, for other types of services that the company may offer, and things like stop-loss revenue from the stop-loss insurance or reinsurance model that a company may offer as well. Kind of coming down through that, you get into the health benefit ratio, and that's really the percentage of the revenue that is paid out in medical or other claims. And so that's basically, think of that as the cost of goods sold. The company is paying for the medical services that the individuals who have contracted with it need. And this is kind of that line item. And for almost every insurance company, it's somewhere between 85 and 95% of the revenues go out the door. In the insurance business, the federal government requires that you can't go less than 85% for a number of different products, or else you have to pay that back in premium, especially in Medicare and Affordable Care Act businesses. So it's a balancing act of making sure you're paying for the services in the right way and balancing the cost versus the revenue. We'll talk a lot about how that kind of gets done in a few minutes. The next piece is the SG&A percentage, and that's really all the people and technology and buildings and everything you have to make paying those claims possible. The contracting staff that works with providers, the people who pay the claims, the people who look at fraud, waste, and abuse, all of that's kind of built into that. And that's a really core area for any insurance company to manage, because controlling those admin costs is probably the trickiest part. You can always hire more people, you can always have more technology, but you have to say, does it add any value for you? And so that all kind of flows down into the bottom, and that's where you're getting your net income. And the intent is, for most insurance companies, they're aiming somewhere between 1% and 4% of that revenue is probably where the net income is going to fall, given all the other expenses that they have and how that works with taxes and everything else.
So I'll ask a question on this. There are so many things we can ask off of this, but in terms of revenue, what are ways that health plans can help themselves on the revenue generation side? So, I'm thinking of things like risk adjustment. I'm thinking of things, star ratings, if we're talking about Medicare. Can you talk through a little bit on that and how that impacts revenue?
Absolutely.
And then, Jess, I'm sure you have some other questions in there as well.
So revenue is a complicated conversation. On the commercial side,
let's do it.
On the commercial side, so working with companies, it's very much a negotiated rate. An insurance company will use their actuaries, individuals who look at medical risk and population risk, to come up with a price for a population. Once they do that, then there's always the negotiations. So you know what your medical risk is, and then you kind of go back and forth with the customer to kind of price this out, because you're never the only company bidding on it. And so you're trying to maximize that revenue you can take in while minimizing the expected risk of the cost. On the Medicare side, so Medicare Advantage, you have a number of ways to try to improve that revenue, mainly through, as Lon mentioned, risk adjustment. And all that is trying to say, if someone has a lot of complex medical conditions, if they have some illnesses, you're capturing that information and sharing it with the federal government, with CMS, the Center for Medicare and Medicaid Services, so that they can appropriately pay you for the risk and the complexity of the individual you're trying to support. Medicaid plans have similar things depending on the state. Some are just very simple models that they look at a population. Some are more complex, where you have a similar thing to Medicare. And then the Affordable Care Act business has the same type of thing as Medicare does, where you're sharing out that risk, but there's balances of the risk pool in terms of total population. So in Medicare, it's kind of an absolute revenue gain. In the Affordable Care Act business, it'll be looking at it state by state And there always are winners and losers. If one company gains a little bit in the risk adjustment revenue, somebody else has to give it back up because there's a set amount available and it's always a set of trade-offs.
That's interesting. So, Mike, I'm gonna switch us a bit here. So, a lot of our listeners, a lot of folks that tune in, they're entrepreneurs. They're looking to make those sales to health plans. And you've done such a fantastic job of explaining this. But if I'm sitting in that entrepreneur seat, how do I think about the different stakeholders involved in how I should target my conversation in terms about the way I speak about the value of my program to kind of match what you've just walked us through?
Sure. It's sadly very simple. If you think about the income statement, there's a revenue line, 2 cost lines, and a net income line. If you're the entrepreneur trying to help a health insurance company want to impact their business, whatever you do has to flow down to that net income line and make it bigger. So that's either managing medical costs better, increasing revenue through various mechanisms, or finding ways to reduce the administrative cost that a company has to pay to get the work done. Those are the really big focuses. Because if you're working with an executive like myself at a health plan, every conversation is how are we finding a way to take the fees that you want to charge as an entrepreneur and turn them into a return on investment. And so that's always going to flow down to the bottom line. If we can do any of those things, it's a very easy conversation. If that's hard to prove, it's probably going to be very hard for you to convince someone like me to talk to you further about the value of the offering that you have.
So at the end of the day, it comes down to ROI, and people need to understand that. And they
Yes.
they need to set up their company in a way that they're tracking data to be able to prove ROI, because that's going to be incredibly important in any plan that you work with.
Absolutely.
So
if you can't explain it to your mother what the return on investment is, you probably need to go back and work on that again.
That's good advice right there. I love that.
Exactly. Exactly. So let me ask you this. What are some big areas right now that you're thinking about, or maybe to keep it even a little more general, folks like yourself are thinking about? What are some really big targeted areas that you feel in 2024 are going to drive a lot of value for your organization?
Sure. So one of the biggest trends we face is that the population in America is aging and aging quickly. You have this large demographic.
Except for us.
Except for you, Juan. I might be a little bit. Yeah.
That's not true.
Definitely aging.
That's not true. Go ahead. Sorry, Mike.
Oh, no problem. So you have this big population bubble, the baby boomers. They're now mostly in retirement or heading towards retirement. And so a number of them are eligible for Medicare. So all of those medical needs are getting met now by a federal program that about 50% of that is done through private companies and about 50% of that is done through the Medicare fee-for-service side on the federal government. Medicare has been an unbelievably successful program in terms of helping the elderly stay healthy, helping them stay out of poverty, helping them have better life. So now they're living longer. And so the core challenge for Medicare, for the federal government, for the companies that do Medicare Advantage is how do you support that population as they're transitioning from where they're living today to wherever they need to be later with all their various needs of hip replacements and knee replacements because they all love their pickleball and they got to get out and play pickleball. And so you got all these things that are out there. How are you supporting that? How are you finding ways to lower that cost a little bit for all of these to make it more effective? How do you get somebody out of the hospital faster to recover better, or maybe not have to go to the hospital at all? How do you get them to leverage the medications they're on better so that their chronic conditions are better managed? That's probably the biggest thing that we're focused on. And you had United Healthcare, you had Humana, a number of the large national players talk a lot about their Medicare Advantage businesses and the concerns they have for cost. That's the big driver of what's going on with that.
Especially with post-COVID rebound on utilization. And then another thing that's come up a lot, if you want to comment on this, is V28 for risk adjustment. There were changes that came into play last year. which seems to be putting everybody's hair on fire because it's having a big impact on revenue. What are you seeing with that, and what kind of adjustments are you making to kind of counteract what is happening over there?
Absolutely. So V28 is just a shortcut of version 28 of the risk adjustment methodology that Medicare does. Not a problem. I thought I might have to explain that one.
Thank you.
The biggest thing we're seeing is that CMS is tightening up the rules. So you had the ability to submit a lot of suspect conditions. The data may say this person has diabetes, but you don't have a real diagnosis of diabetes yet. Now you're really having to back that up with documentation and details and a lot more rigor and expectations from CMS. And so the expectation is that the revenue available from properly identifying someone's health conditions and getting that set up, the revenue is going to come down. And so that's going to tighten that mix between the revenue and the cost and the net income. And also then, population needs are going up. Revenue's getting pushed down by CMS as they're trying to make sure that they're paying for real value. And so you're getting a shrinking impact on net income.
Gotcha. Makes a lot of sense. Jess, do you want to take down the slide that we have? I think we're off of that for now. So that's really, really helpful. Jess, is there anything that comes to mind right now? If not, I can take us in a little bit of a different direction. I want to make sure that...
No, I think it's maybe one more question kind of on the trend piece. So, everyone's concerned about this. I go back again to some of the listeners that we have on the show. What kinds of successful programs generically are you seeing that are helping meet some of the objectives that you just talked about? Like they can be types of programs, they could be different programs that are addressing very specific needs that you've seen in the marketplace, but kind of talk to us just about that trend a bit.
Absolutely.
And Jess, can I add on? And what are some areas that you'd like to see some new solutions come to bear? Right? Since we do have early stage entrepreneurs. So if you have ideas of areas where people could use help, this is a great place to share it.
Very good. I think first and foremost is around medication adherence. And what I mean by that is that if you're a person who has a medication your doctor has prescribed to you, that you take it as expected and keep up with it and get your refills and do the things you're supposed to do. When you look at the healthcare industry in total, medication costs right now are between 30 and 40% of the total spend in healthcare. And it's only going up as new drugs come in that do amazing things that can cure diseases that we never thought we'd be able to impact. But it requires that person to really stay on top of that. So there's a number of services that we're working with that we're exploring further on how do you get someone to remember to take their medication every day. There's some that are video based where the individual sends in a video of them taking the pill every day and they get a little reward or a little tick mark for that. There's some that are technology based depending on the complexity. There's some services that will go out and do infusions into a person's arm, right into the vein, and they're home, trying to just find different ways to make sure they stay on top of their medications. Because if you think about it, you have someone who, if they keep up with their insulin, if they keep up with their other diabetes medications, they'll live very comfortably for a very long time. If they don't, they'll end up in the hospital and then they'll be facing a lot of adverse consequences because their body is reacting to not having the medications that they need. So that's kind of one big one for us. I think the other one is trying to figure out how to treat people outside of hospitals. And this has been a long-term trend, but technology and telecommunications and just the nature of people's living arrangements have been driving this even further. How do you give them basic primary care? How do you give them more advanced care when they're at home? Hospitals are a great place to get treated for something that's acute and risky. And when I say acute, your life is being threatened and it has to get addressed right away. Hospitals are a terrible place to be in for something where you have a chronic condition like diabetes or some of those types of things where it's just an ongoing management because, there's a lot of airborne diseases and other things that fly around in hospitals because people there are sick. And so you can pick something else up while you're there. Much more enjoyable to be at home, get treated at home, get taken care of at home. And so I think that's another area of opportunity of how do we continue down that path to figure out ways to help take care of people where they want to be and not force them to go to some large building in a city center where they just don't want to be at all.
That makes sense.
Yeah, that's great.
So great feedback. One thing Jess and I see a lot are health plans are looking to capitate out and push out risk to other organizations that are willing to take on risk. So we're seeing a couple of different things, right? We're seeing health plans pushing it out to provider groups and there as a percentage of premium. And then we're also seeing pockets of risk getting capped out to vendors that are taking, risk on those with 6, 7 chronic conditions or those that have CKD, or kidney disease or things like that. What are you seeing in terms of capitation? Can you explain to the audience why that's so important for health plans to be able to take that risk and be able to shift that risk off their books?
Absolutely. So health insurance in its end is a fixed revenue variable cost business. And so you're going to get a set amount per person per month. You're also then going to have to pay out a variable cost depending on health issues or things that happen to them. One way to mitigate that is to say you can give an organization 80% of your revenue and now they're responsible for that risk. Generally not a bad approach, but it requires a couple of things to make that work. One, the organization you're talking to has to have the capital to back it up. So if something goes badly, you know what's coming. And two, you as the insurer then have to keep some capital in reserve because your regulators don't care if you delegated out your risk. If it comes down, that company goes bankrupt tomorrow, you still got to pay the claim. And so you've kind of got layers of this you're trying to manage financially. And that's just the pure financial piece. What we also then see in terms of once that financial risk is moved to a provider or to a vendor, they're much more engaged in trying to drive health in a better direction, drive performance in a better direction, because now their organization's on the hook. They're not just getting a monthly fee from someone, and whether it goes well or not, they still get paid. They're taking on the financial risk. And so now they have to take on the operational risk. They have to take on the medical risk. They have to try to think their way through how to find a population to support and how to make sure that population stays as healthy as possible so that they can make money off of the deal that they put together.
Makes sense. I'm guessing that also, go ahead, I'll just make a comment and then go over to you, Jess. I'm guessing that also helps quite a bit on the administrative cost side for you. I'm assuming it's considerably lower administrative costs if you're pushing that risk out to somebody else managing it. Is that the case, or is that not always the case?
It's a good point. It really does help us there because we're looking for that organization we're pushing it out to take on some of the administrative functions we might have done in terms of medical management activities, in terms of outreach and communications, in terms of customer service. So some of those things then get pushed to another organization. And so that is a benefit for us. But we always have to make sure that the individual is getting paid well and things are getting taken care of.
Makes sense. Go ahead, Jess.
How does a health plan, you've been at several different health plans over the years, how do health plans think about risk distribution? So how much risk do plans like to kind of farm out to different vendors and provider groups and things like that? Is there kind of a sweet spot that makes sense with the P&L, or is it just kind of more evaluated by line of business and what that solution offers that plan at the time?
It's really evaluated by the capability of the group we're talking to take on the risk. And so if you have a lot of very mature health systems, integrated care delivery organizations that have hospitals and providers and home health pieces, you can do a lot of things with that. If you have providers who are more family practitioners and just aren't used to it, it's really hard to push that risk out. So we would like to push out more risk. We'd like to get that closer to the individual being treated. But you have to really look at the organization's maturity and what they're capable of taking on.
It makes sense.
Does. So, hey, Jess, I was thinking it might be a good time for us to shift a little bit over to roles within an organization and what are the priority and key points. Because once again, listeners, and I'll re-anchor to it, right? Early stage founders healthcare investors as well as health plan executives. Can we talk a little bit, Mike, about the different roles in an organization and what are the key areas of interest for them? And if you were an early stage founder, what are the value points that you would really highlight with each of these folks? So if I think about like, a CFO, people have preconceived notions of what would be important to a CFO, but it's not always exactly what you think it's going to be. And then a chief medical officer and others. Could you kind of take us through who are some of the key players and what kind of solutions would they be interested in and what are those key value points?
Absolutely. So we'll kind of work our way from kind of the medical side to the administrative side to the overall, organizational perspective. So we'll start with the medical side. So you have the medical management organization. So you'll have a leader of care management, which is working with a population of people and making sure they're going to the doctor, taking their meds, getting the treatments they need, and then advocating for them with providers and hospitals to get things done. You'll have a group of people, utilization management. They're the ones kind of enforcing the policies and the rules and making sure that providers are following things that are expected. You'll have a group of folks, provider network, and what they do is all the contracting with providers. They administer the risk programs, the value-based programs where you're trying to get the provider to pay more attention to the outcomes than just getting paid every month. And then you'll have an entire organization for quality. And when we talk about quality, that's our way of measuring if the medical activity that happened was the right medical activity. So was it following the expectations of national guidelines? Did the provider do the right things in the right way? Now, there's always the financial of everybody getting paid, but just as important is, did the member, the individual get treated well, get treated right? And are the doctors looking at the right things to make sure they're getting everything that they need? So that group of people is very much focused on that medical loss ratio, medical benefit ratio, and how to find ways to meet the needs of the individual at a lower cost point. So does somebody need to be in the hospital? Yes or no? If they don't, is there a lower cost place to provide that service? Is there a lower cost drug that may have just the same level of impact? All those are kind of the questions. And so that's really a group of people focused on kind of the cost, the benefit, and the satisfaction of the individual getting the services. So any
Makes
questions
sense.
on that one? Because that was kind of a long explanation on just one small part of it.
Yeah, sure. So that's really valuable. First thing is you've mentioned medical loss ratio, benefit cost ratio being, and if you could just comment on, they're the same thing, correct?
Yes.
What other ways are there of saying that, just so our listeners don't get confused when they hear multiple things? I feel like there's another one that I'm missing. Can you think of what that is off the top of your head?
So-
Medical loss, benefit cost, and I feel like there's one other one.
There's the member benefit ratio as well. That's kind of another
Member benefit
variation
ratio.
of it.
And I feel like there's another one that I'm kind of missing there, but that's helpful. I'm going to make a comment here. And I'd love your insight into it. And I don't know how popular of a comment it's going to be, but I'm going to throw it out there anyway. So my role has typically been on the growth side of the business. When it comes to selling to health plans, in my opinion, you have to go high in the organization to be able to get the right amount of attention. So if you're selling something that maybe might be of interest to utilization management or care management or some other part of the organization, I personally feel like you have to start at like the chief medical officer level to be able to get that attention and for them to be able to delegate down, because that typically is where the decision lies or the ultimate control lies. Do you agree with that? I'd love your feedback on something like that.
I'd say yes and no.
Okay.
Because it's a somewhat risky strategy. Because if you don't have your story together, if you don't have your value proposition really tight, if you get time in front of that chief medical officer, you've got one shot. And if they hear your company name again and you really did not deliver the conversation that they were expecting, you'll never get back in the door. And so if you look at some of the lower folks at the VP level, the director level, it gives you the opportunity to learn about the organization, to kind of build up some relationships, to get a feel for what might be important and not important, so that when you're in front of the chief medical officer, you know what's coming and you've kind of found your way around all the hot buttons that person may have. And you already have answers for the conversation.
different perspectives are always helpful. And I really appreciate that. And I think that's a good point, especially as we talk about early stage founders. They're going to need to make sure that their story is together and tight, and they've got that strong ROI that we've talked about before. But as you get a little bit stronger, I do think there's a lot of value in starting as high as you can in an organization. But I can see where, if you're not prepared, that could backfire pretty quickly.
Yeah, I think that's one of the biggest challenges we see is somebody comes in with their standard pitch deck and they start to go down their standard pitch deck. And it's like, you guys didn't even look at our website, did you? Yeah, that's
do you get a lot of that?
Not as much as I used to, but there's still, some folks who are really early stage that are all excited about their idea and think it's absolutely brilliant and haven't kind of tested it against the market yet and realized where it may be brilliant and where it may not be. We find some folks who are quite prepared for that conversation.
Gotcha.
I think that's where the mentors, the advisors, those types of people come in.
Yeah.
In my opinion, of being an early stage founder back in the day, that is where you make sure it is tested before you put it in front of those high executives. So you make sure you are tight, your story is tight, and you've been coached. Guys, get a coach. Everybody out there listening, get a coach.
Yeah.
Jess is a huge fan of coaches.
Because Mike's right. You get one shot at it. And, that
are you going to make me? Are you going to make me get an Eminem 8 Mile here with the song? I will go there. I will go there right now. You know that about me, Jess.
Yes.
So that's anyway. So we talked a little bit about the medical side. Can we talk a little bit about the financial side? So if you're, what are the kind of things for a CFO? And then let's go to a CIO or others. And then, hey, why not? Let's talk about a president of government markets such as yourself. What are the kind of things that, folks like CIO, CFO, president of government markets, what are the things that they would be interested in? And what are kind of the decision-making things that are in the back of your mind?
Absolutely. So we talked a lot about the medical side. Everyone else is so focused on how to make the administrative costs lower. So you've got the CIO, the chief information officer, is sitting there looking at their technology platform and saying, I pay millions of dollars a year to one of these vendors to supply the services I need. Can I save $100,000 on that next year? Can I save $1 million on it next year? Or will the service you're offering, like a generative AI solution, give you the ability to have less people doing customer service and doing basic answers, and they can go do something else? Or you do a website to do the same type of thing. It's always that cost benefit trade-off of what's the real impact on the business, and in terms of where do you point to in the income statement to say you're having that impact. The CFO will look at things very much in the same way. They'll be looking at things in totality of saying, how are you impacting the cost structure of the organization? Or how are you helping us find more revenue in the way to get it done? And what you'll find is the CFO and the CEO or the plan president will probably have the same questions and the same answers most of the time. The CEO will also be asking, how will this impact reputation? How will this represent us in the community? How will it align to all the other vendors we have? Because in health insurance, we have a ton of vendors. And so it's always a question of kind of how all these things come together to present a holistic solution. But over and over and over again, it's going to be, are you improving revenue? Are you driving down cost? Are you doing something that makes the financials of the organization more effective so that we can offer the services we need to do in a better way and try to find ways to offer other services that may make us more competitive or differentiate us in the market?
That's great feedback. You mentioned one thing that I'd love to dig in a little more on, AI. What are some things that you're seeing, if you look at it from a health plan perspective, what are some areas that are really interesting from an AI perspective for a health plan?
Absolutely.
Because you hear AI everywhere and I just don't even know where to go with that. So I'd love to get some feedback.
No, it's a really good question. Customer service is probably the first thing. We get a lot of phone calls about what's the status of my claim? Am I eligible for this service? All those types of really basic things that an AI can answer just as easily as someone else. Plus, with all the turnover that exists in that business, you usually see a call center have 80 to 100% turnover a year. And so AI really helps in training, developing, and kind of keeping the quality levels up. More Interestingly, from there, you get into utilization management and authorizing claims, authorizing services. And then the payment of claims is kind of a third area that's starting to develop and evolve. Because right now, all that's set up with very complex coding arrangements where you have to set, 1,000 different buttons to make sure that the claim pays just right. AI can read through a massive amount of claims you paid previously, read through all the rules, and help you do that differently and maybe much more effectively. So I think there's some things there that have potential. The question we always run into with healthcare is what's the risk? And that's where I think AI will probably move a little bit more slowly in healthcare than some other places, because we're trying to understand what that negative impact could be for an individual and make sure that we're not doing that too easily or having too many impacts early on until we get a really good handle on how the AI models are working, what they're delivering, and why.
Got it. Well, one thing I've always really appreciated about Blues Plans is that your focus on reputation is, in my opinion, so high and higher than any other that I see in the industry. And your network is so incredibly important. So making sure that things are going to drive value and not cause damage is critically important.
Agreed.
Mike, would you agree with that? Or that's my opinion of the Blues. I mean, incredible networks and really focused on reputation.
Absolutely.
Is that how you see it as well?
In many cases, we're organizations that are locally based, locally employed, and we've been in our markets for 80, 90, in some cases, 100 years. We're there to stay, and we want the community to view us as part of the community. And it's important for us to be viewed that way. And so most of us are not-for-profits. We kind of have a different type of model. We need to meet our financial plan, and we need to manage the risk, but we also need to make sure we're having a very strong impact for the community and for the members and for our customers as well.
That's great.
Makes sense.
One of the questions I have for you, Mike, just kind of backing up when we talked about all the different key stakeholders in an organization when we think about, selling to them. I like a good case study. And I'd imagine as a professor, you like a good case study. Is there a particular vendor that you've worked with over the years that you'd be comfortable saying, like, this one was so successful? It stands out in my mind because of the experience, the data that was collected, and the success it delivered.
We're really putting Mike on the spot.
You
with
really
this
are.
One. So, Mike, if you have an answer, that's great. If not, we understand. But
or even a type of vendor, if you're not comfortable saying the name, but just like a category, or is there even one that meets that kind of criteria? I think there's so many vendors and that try and get in with health plans and kind of setting yourselves apart like that. That's a big deal.
It definitely is. There's one that comes to mind very recently. Social determinants of health have been a big topic in our industry, and that's really the negative impacts of poverty on a person's life, in their housing, in their transportation, in their food, and just in the stress that they have due to poverty. We have one vendor that recently came in and presented us with a actuarially evaluated case study showing how they really did have a financial and revenue impact for our population through the work they were doing in social determinants. And this is a rarity. It's really hard to find ways to prove that you're having an impact on something that is nebulous. But they had a truly sound, financially reviewed study that proved that they were having that impact and able to repeat it. That was incredibly powerful. They pretty much opened up with that. And then we started to say, so how do we talk about a contract? Because
so did that fast track?
Oh my God, yeah.
Did that help fast track?
Yeah, it was one meeting, and then we were in, okay, let's talk about a pilot and how do we get started?
So when you say fast track in the health plan world, what's that, about 6 years? I'm kidding. What is fast track to you? I mean, when I think about a typical sales cycle on health plan, you're typically looking at 12 to 24 months. I mean, you can do 6 if you're really good. What did something like this do for that sales cycle?
That brought it to about 3 months.
Oh,
wow.
whoa.
That's fantastic.
That's
I think
impressive.
I think I've been able to get down to 4 or 5, but 3 is amazing. That's fantastic. So yeah, I'd love to hear more about that one offline when we connect next time.
Mike, was that a case study they conducted themselves and then presented that, or did they hire an external company to do that for them?
They did it themselves, and then they had an external company, a very well-respected actuarial firm, do the review, and the actuarial firm was willing to put their name on it, that they said it was good. And that was a real stamp of approval and quality that is very rare for us to see from most of the vendors we're working with.
Some great advice for those vendors out there. Mike,
that is gold.
Gold stamp of approval right there.
There's your gold right there. You got to be able to take it. So, and I know we've been chatting now for a little while, so we're going to wrap in a little bit, but I wanted to ask this. Are there areas that you see that are really in need of new solutions? So if we're looking at the really super early entrepreneurial person that is looking to get into healthcare, are there problems that you feel like are solvable that need to be solved or need to be improved greatly? Is there anything that comes to mind?
I think there are a couple of areas. One is in the Medicaid population, and it's connecting and educating people on their health. Because the population is living in poverty and is financially challenged, they tend to have unstable housing. They tend to move around a lot. They also tend to not have a lot of time to spend understanding the nuances of their medication, their treatments, their conditions. We have a really hard challenge in trying to find, reach, and connect with these folks. We had a couple of vendors that were doing really well with that. Unfortunately, one of them wasn't able to maintain their funding, and so they had to move on and do some new things. But that's probably one of the biggest areas for us is in that Medicaid area. How do you connect with someone? And once you do, how do you maintain that relationship? Because we find if someone's engaged with their care, if they're going to primary care on a regular basis, they're taking their medications, they'll have fantastic health. Things will go really well. If they're not aware, if they're just, not able to keep up with all the things being thrown at them, or they have a doctor who spends 3 minutes in the room and doesn't really explain things very well for them, and they don't know what questions to ask, we find that they end up with a lot more health struggles. And we want to try to avoid that.
Right. Makes sense. That's some great feedback. Jess, do you have any more questions? I have one that's lingering in the back of my mind, debating whether I want to ask, but go ahead, Jess.
You should. One more I have. Medicare Advantage is just been ripe for innovation. There have been so many solutions targeted at MA to serve those members and to, make those lives better. I personally feel like Medicaid now is really ripe for innovation with a lot of the, we're talking a lot more about rural health and how to get care to them so they don't have to, you mentioned earlier, drive to a city center to get the care that they need. What kind of innovations are you seeing in Medicaid that make you excited about different parallels that can be drawn to the Medicare Advantage space, maybe where we were 15 years ago?
So I think one of the biggest areas of opportunity for Medicaid is that pediatric side. So everyone kind of under the age of 21 in terms of their the treatment and the services they receive, and all the preventative care. We have so many expectations, both from our regulators and from the population, of how to help them with vaccinations, how to help them with other treatments. There's a number of vendors who are starting to explore that, how to kind of stay on top of a number of these things and make sure that the individuals and the parents really kind of understand what's needed. And then that kind of also leads into the very earliest stages of pediatric care and maternal health. When we look at minority communities, especially the Black population, the maternal health statistics are depressing. They are way off the charts in terms of what should be acceptable. And I think that's a core area for us to be focused in on how to better improve maternal health, better improve it, especially in the low-income population. Medicaid right now pays for 40 to 50% of all births in the United States. And so just by impacting that and making sure that someone who is low income, someone who is a minority has, equal or better maternal health outcomes than anybody else in the country, I think is a critical area for us to be focused on to really bring health equity and kind of deliver the promises that we have as in terms of providing good care.
That's great.
So Jess, that was a great question. The question I was going to ask, I'm actually going to put off to the side because I'd rather double down on yours a little bit. And, some other time we could always have Mike back on it another time to talk a little bit more in depth. But the challenge that I see with Medicaid with vendors is Medicare pays better, right? And Medicaid doesn't pay as well. And there tends to be a challenge from entrepreneurs on being able to make the appropriate margins in Medicaid. How do you kind of reconcile that if you're advising an early stage founder and they're like, we've got a model here that's just really right for Medicaid, but Medicaid, man, they just reimburse so little and it's so challenging. How do you reconcile that?
It's a very tough one. I think in Medicare or Medicaid, you're dealing with very tight reimbursements and very tight revenue structures if you're trying to provide services to a health insurance company. Simply because as we talked about, the medical cost, 85 to 95% of the revenues going right back out the door to support the medical needs of the members. There isn't a lot of money to move around either place. Because both CMS and the Medicare side and the states and the Medicaid side play you roughly a flat rate per month per person, adjusted a bit for their medical risk and their complexity. But, you kind of have a real good sense of here's all the money you have to play with. And then how do you maximize every penny of that? So I think either way, you're going to find those are challenges. The real question becomes, how do you create some scale? How do you create some volume? How do you create some density? So if you're offering services for Medicaid, you really want to try to find multiple health plans that you can work with in the same geography. And we see that with a lot of our vendor partners. They don't just work with us. They work with 3 or 4 Medicaid plans, and that gets them the density, the scale, the ability to have a real impact in a particular geography that they might not be able to do, and makes that fixed cost that they have to do of staff and equipment and everything able to be spread across multiple players.
That's great feedback. Have you ever, and I kind of picture this a little bit in like the mafia kind of way, have you ever seen a meeting of the minds where the different health plan, let's say presidents came together, a vendor kind of brought them together to be able to actually get scale before launching in a market? It seems like a vendor launches with one and then runs around and tries to get contacts or contracts with others. But have you ever seen everyone kind of put a meeting of the minds together to come together on the same page and tackle a problem? Have you seen any examples of that?
Actually, we have a very recent one. Redetermination for Medicaid happened as part of the pandemic, and redetermination was going through all the population of people who have had Medicaid eligibility since March 2020 and haven't had to go through being evaluated for their eligibility again since. We had to start this in April of last year. And one of the things that the 9 Medicaid managed care organizations in Maryland did together is we contracted with one communications vendor. And then we convinced the state to contract with that same communications vendor so that there was one message coming out from all of us, the state, the MCOs, and the providers. And it was one consistent message with one consistent approach, tracked, measured, driven, because it was in all of our best interests to have a common solution that worked really well and that we could all trust. And we found an easy way to kind of divvy up the financing and the commitment. The Medicaid Association members threw in about $2 million. The state threw in another $1 million. And we really had a wonderful outcome in Maryland in retaining individuals in Medicaid and having the impact of educating, making that population aware, and making sure they got through all of the administrative processes to keep their eligibility for Medicaid.
That's fantastic. Great. That is great. Was that driven by the state, or was that driven by a Medicaid plan that tried to bring everyone together? It was
driven by the Medicaid Association. So all 9 of the plans together. We had a few conversations and said, yeah, we've got to be proactive. We've got to drive this. We went to the state with the proposal, and they bought right in, and we took off from there.
That's great. That is awesome. Well, hey, I think it's about time for us to wrap up. I really appreciate it. Jess, do you have any further questions? I mean, I've got plenty of questions. We could always have Mike back on again. I'd love to dig in a whole lot more on this whole Medicaid redetermination piece, and that's could be an episode in its own on how that works.
Absolutely.
But are there any things that are burning for you right now, or are we good to close? Go ahead, Jess. Do it.
More.
Go ahead.
Just do it. I have one more question, and just you've had so many really wonderful insights, so I feel like I have to ask this question. All things considered, if you could make one sweeping change in healthcare, just snap your fingers and say it is done, what would it be?
And it can't be fewer podcasts. We're not letting that one come up.
Not a problem. If I could do one really dramatic big thing, I would push for everyone in the country to be in the same financial reimbursement system for healthcare. Most likely something that looks a lot like how Medicare is done today, and that there's a Medicare option for you if you want a government-driven plan. There's a fee-for-service solution that the federal government manages, and you don't have to deal with an insurance company. If you want something from an insurance company or want some of the wide variety of offerings or differentiators that they have, you can sign up for that. But everyone kind of getting separated from having to deal with healthcare from their employer, having to figure out all the various programs of what they're eligible and not eligible for. One system that captures kind of the best of the government-driven side and the best of the private sector in terms of innovation and creating new types and different types of solutions, so that people have a wonderful set of options for their health care, but that they know that they have it, and that folks don't have to worry about it if their job changes or something else flies around, that they have to worry about how they're going to take care of their own health.
That's great. Thank you so much for that. Thank you. So, hey, Mike, what would be the best way for people to get in touch with you if they wanted to? I'm guessing LinkedIn, but what works best for you?
I'll give you my cell phone number. No, actually, probably not a good idea.
We talked about that already, Mike.
Absolutely.
He likes text, preferably after 10.
Not that Lon has ever sent me a text after 10 p.m., but he has. Yes, that's right. No, the best way would be LinkedIn. Easily found on there, and happy to have people reach out to me. Okay, great. And Mike's last name is spelled Rapach. And Jess and I want to wrap up this episode, say thank you so much for tuning in. If you have topics that you'd like to hear as a part of the podcast, please reach out to us. Our website is thehealthcarehustle.com. And please subscribe through your favorite podcast network or through YouTube. And we just want to thank Mike for joining us and for another great episode. Thank you so much. Thank you.
Thanks, Mike. As we wrap up this episode of The Healthcare Grind, we want to thank you, our incredible audience, for tuning in. If you found today's insights valuable, don't forget to hit subscribe and leave a review on your preferred podcast platform. Your feedback fuels our grind. For more exclusive content and updates, visit our website, healthcaregrind.com. Until next time, keep grinding, stay informed, and lead the charge in shaping the future of healthcare. This is Jess and Lon signing off from The Healthcare Grind.